Thank you so much, Catherine. And I will just let everybody know we are recording, but we're recording the talk. Not everybody's faces will come up. And yeah, I think I'm just going to hand it over and let Catherine, if you would kind of introduce yourself a bit and just get started. And again, thank you, everybody. How this will unfold is Catherine's going to talk and share with us her work. And then we'll have some time for Q&A, and I'll facilitate that, and we can go into full screen with everybody, and you can raise your hand or type it in the chat. And if there's anything that comes up through the talk that you want me to highlight as soon as we're done, just please type it in the chat. And again, thank you so much for being here. And Catherine, thanks so much for taking the time. We're really delighted to have you and to get to work with you as well as one of the postdoctoral fellows within our unit. It's very exciting. So over to you.
Okay, well, thank you, Vicki, and thanks for the opportunity and letting me come in and share this research with all of you. In terms of an introduction, I'm adjunct assistant professor in the School of Social Work at the University of Windsor. I'm also a sessional lecturer and work at the Dahlana School of Public Health at the University of Toronto. And as Vicki said, I'm also a postdoc in the capacity unit here in the School of Nursing at UBC. So that's just sort of me a little bit. And I do a lot of community-based harm reduction research and have done so for years and years. Today, I'm hoping to talk to you about exploring the perceived impacts of safer supply program engagements on criminalized income generating activities, the perspectives of the program clients and service providers of 4 specific programs in Ontario, Canada. This research stems from a larger project which examines the implementation of 4 safer supply programs in Ontario specifically. So before I start, I wanted to take a moment to acknowledge that the research I'm presenting today took place on the traditional and unceded territory of the Anishinaabeg, the Haudenosaunee, the Lenape, and the Attawandaron peoples, which are covered by treaties dating back to 1792 in what is colonially known as Ontario, Canada. And we're mindful of the broken covenants and strive to make this right with the land and with each other. And I'm constantly reminded of my responsibility as a researcher who has the privilege to work on this land, and the need to consider, in light of the current drug poisoning crisis and the ongoing criminalization of substance use, and how this continues to disproportionately impact certain groups, including Indigenous peoples, and striving to commit to engage in culturally responsible and anti-oppressive research that addresses this and really works to improve accessibility and equity in healthcare and well-being for these groups. And I know this is typically done at the end, but I wanted to start with all of my acknowledgements. So I wanted to also acknowledge all those who took part in this research, including people with lived experience and the service providers who really took their time to share their experiences and their expertise with us. And I wanted to also thank the 4 Safer Supply programs for their support of this project as well. And then as a final part of the acknowledgement, I wanted to acknowledge the broader research team that worked on this project, including the co-PIs, Dr. Carol Strike and Dr. Adrian Gouda, the other co-investigators on the study team, and the research assistants and research coordinator who were part of the research team as well. And then acknowledging the funding for this research coming from the Ontario HIV Treatment Network, and also being supported by the University of Toronto and the University of Windsor. So as many of you know, in North America, we're in the midst of a toxic drug poisoning crisis. And in Canada, there have been over 38,000 opioid toxicity deaths since the start of 2016. A total of 7,328 deaths occurred in 2022 alone. This is an average of approximately 20 deaths per day, and around 2,500 of those were in Ontario alone. Unregulated fentanyl and fentanyl analogs continue to be major drivers of this crisis. 89% of deaths in Ontario in 2029 involved some form of fentanyl. And we're also seeing a lot of benzos in the supply as well. The toxicity of the unregulated drug supply is really also the product of the ongoing war on drugs and the criminalization of drugs and the people who use them, and the prohibitionist drug policy, stigma, and discrimination that really also play a role in worsening and continuing on this crisis. COVID-19 really exacerbated an already terrible situation, reducing access to the unregulated market through disruptions in supply lines and necessitating further action, and including, supporting marginalized or people who use drugs to follow public health guidelines like distancing and isolating, which again put them at risk of overdose as well in a variety of different ways. And as a response to the changing reality of COVID and the accelerating overdoses, Canada's in the portion or in the position of currently piloting some safer supply programs, which provide individuals who use illicit opioids with off-label prescriptions for pharmaceutical grade alternatives to the toxic drug supply. So folks of that community and with lived experience, including the Canadian Association of People Who Use Drugs, have been calling for, in various capacities, formal and informal, for a safe, legal, and regulated supply of drugs for a very long time. In terms of safe supply and what that means to them, it is a safe, legal, and regulated supply of drugs with mind and body altering properties that traditionally have been accessible only through the illicit drug market. And this is obviously different from the medicalized or the prescribed model we now have running in Canada, in that the primary goal of that model is really around reducing overdose risks through the provision of pharmaceuticals of a known quantity and quality as well, and it isn't quite the what the Canadian Association of People Who Use Drugs was calling for, but this is the programs that I'll be speaking to today. So I'm going to be talking about medicalized safer supply offered in a primary care model, as that's the primary approach in Ontario. However, this is just one end of the spectrum of safer supply that's possible and that is available even across Canada. There are different programs that and also pilot projects that are looking at different drug options, for instance, stimulants, and different care models and delivery systems. So in Ontario, safer supply programs are typically embedded in primary care and delivered in community health centers. However, these programs were also deployed to COVID isolation hotels during the pandemic, and there were service providers who were prescribing in community prior to the pandemic as well. What's offered in Ontario based safer supply programs typically is take-home Dilaudid or hydromorphone, and for some daily observed Cadian slow-release morphine as a backbone to prevent withdrawal typically. And what this actually looks like for a client who might be on this program is they would go to the pharmacy daily and take their Cadian, which is 24-hour slow release, and then get their Dilaudid and be able to sort of use that however they like, including injecting if that is their preference. The key piece here being that it's a regulated and consistent supply that people have control over, and so that they can regulate their use throughout the day, sort of giving them that flexibility and control. So as a bit of background to this broader study, we initially applied for funding in 2019 to examine what were then being referred to as emergency safe supply programs. So this is pre-Health Canada sanctioning and the SUAP funding. Physicians were doing this work in the province and had started to be more open and about that. And we received funding for this larger project in February of 2020. And then the pandemic happened, so we had to pause our research. And in the meantime, these safer supply programs were growing and adapting to sort of the new realities of COVID. And by the time we were able to start doing our research or pick up the study again, there were established programs for us to look at. So in terms of this research, between February and October of 2021, we interviewed 52 program clients across the 4 programs in Ontario, as well as 27 service providers across those programs. In terms of the objectives of the larger study, we wanted to examine from the perspectives of both clients and service providers how these programs were being implemented, what were the experiences of being enrolled and remaining on the programs for clients, and sort of what were the perceived impacts of these programs on the lives of clients. Although, as I mentioned before, the primary purpose of safer supply programs was to really reduce mortality and health-related harm stemming from the toxic street drugs. These programs are having a broader impact, and we heard that across the board from both clients and service providers. So my colleagues and I on this project have presented on different health outcomes in terms of decreased overdose, uptake of harm reduction services, reduced injection, increased access to HIV and HCV care elsewhere. We've also have some data coming forward in the next little bit about the implementation challenges and benefits of these programs during COVID-19. But today I'm going to focus on what we heard from clients and service providers about the potential impacts of engagement in these programs on crime, victimization, and engagement with the criminal legal system specifically. So we didn't specifically set out to look at this, nor did we ask directly about these topics, but they came up really organically, both with the clients and service providers throughout most of the interviews. For this project, we engaged in thematic analysis as a team, as a smaller core team, and used a collaborative group coding approach with our advisory group, which included folks with lived experience, as well as the broader research team, providing feedback on our coding structure, themes, and the like throughout the process. And now I just wanted to give you a little insight into who we spoke to as part of this project. So for the clients across the 4 programs, as we can see here, just over half, so 56% approximately, identified as men, 79% identified as white, 17% as Indigenous. The average age for clients was 47 years old, with a range from 29 to 65. Or I guess about a third had their own housing, a quarter were staying with family and friends, and 13% were staying in shelter. And just to talk a little bit about service providers and who the service providers were that we talked to in terms of their roles. We spoke to prescribers, so both physicians and nurse practitioners. And we also talked to registered nurses, and then what we've termed allied health professionals in these programs, which included community health workers, program administrators, systems navigators, outreach workers, and case managers. There were also a handful of interviews that were done with pharmacists. And this data is not included in the analysis today, as they didn't speak to these broader topics. In terms of some socio-demographics for the service providers, most, again, identified as white, 2/3 identified as women, and more than half were between the ages of 30 and 39 years old. So getting into some of our findings and what we learned in talking to both clients and service providers. So in talking to clients, we really started to hear about their lives prior to starting on the programs. And most clients told us about really long histories of involvement with law enforcement, talking about cycling in and out of prison, for instance, with 87% of the clients that we spoke to reporting ever spending time in jail or prison. But if we looked at that in the last year, only 6% said that that was the case for them. So just to share in their own words what participants shared with us, this first participant explains, they put me in prison about a dozen times. And so I ended up going to the penitentiary, and then I ended up with quite a record. And this second participant recounts something similar, saying, out of the last 25 years, I spent about 5 years out of the penitentiary and 20 years in. Similarly, this woman explains, because I was always in jail, I could never stay away from jail. She goes on to tell us about a time when someone asked her how long she'd been in jail, and the guard answered for her and saying something along the lines of, since the concrete's been poured. So these were sort of the histories that folks shared with us. So being on Safer Supply really meant that clients had access to this steady, secure, and safe source of opioids through these programs. And that meant for many of them that they no longer had to rely primarily on the illicit drug market for their supply. This meant that they no longer felt like they had to engage in certain criminalized income generating activities. Most often they talked about theft and sex work to make money to get drugs and to avoid withdrawal, as they were telling us. So as this woman explains, this was both a surprising and a very welcome change. She says, I just couldn't believe that we didn't have to run around and look for them. Opioids didn't have to steal for them. And this man goes on to say, I stopped thieving because I had to, and this is prior to the program, I had to support my habit. So I didn't have any other way of doing it. Stuff's expensive. Yeah, to support my habit, I had to shoplift and things that I would not normally do. And I haven't had to do that since I've been on the program. So that's another great thing that's happened from this program. And just sharing one more quote here, as this woman says, I used to prostitute. I don't have to do that anymore. So that in that sense, I don't have to search to find pills all day. And that part of my life is a bit more stable. So we really saw folks talking about, what this allowed their lives to be like being on these programs. And I'll come back to this in just a bit as well. So service providers also discussed the reduced engagement in theft and sex work among clients. So this nurse practitioner, as this nurse practitioner explains, everyone actually says that it's great not to have to boost or do as much sex work to keep going. Some folks have now started talking about the future. This service provider went on to say, it's like their timelines have changed. It's not about getting through tomorrow. Like they don't have to worry about getting their fix for the next 24 hours. And they talked about how their clients would bring up things like, well, I want to go to school potentially, or I'd like to look into getting into peer training. So the provider talked about how there was some, future-oriented stuff that was coming up for clients as a result of potentially being on these programs. Likewise, another nurse practitioner mentioned that out of the patients who came to them who were actively involved in survival sex work, their estimate was that 97% were no longer engaged in survival sex work and no longer selling sex for the purposes of shelter, food, etc. So not having to engage in criminalized forms of income generation also meant that clients really reported, or we heard from them, decreased risk of arrest and incarceration, which was a huge change for many. As this first participant explains, I was so sick and tired of jail, and they say that's my second home. When the guards see me, they say, welcome home. And ever since I've been doing the program, it's kept me out of jail, and that's my major thing. This woman talked about how she had been in and out of jail constantly. There were points in time where that was upwards of 10 plus times a year. And she went on to say, since being on the program, she hadn't been in jail once in the past 4 years of being on the program. Providers also spoke about how they heard from many of their clients that they hadn't been, as they termed it, in cells once since starting the program. So again, reiterating what clients had been sharing with us as well. And then some of the clients even went so far as to say that safer supply programs must cost less than putting people in jail or prison, and the impact of that, as this very illuminating quote here from this client shows. As he says, the proof is in the pudding. Look in the court system, pull up my file, and you'll see how much counts of armed robbery I got charged for, how much counts of robbery disguised with intents, how many strings of pharmacies, and I'm just one person. Imagine how much other people are doing this. You know what I mean? I've served my time so I can talk about some of this stuff, and this is just one person causing all this strain on taxpayers' dollars. All they have to do is look at what I was doing and look at what I'm doing now. What would you prefer? This man really went on and spoke to us about how he believed if it wasn't for safer supply, he would have continued to do the same things that he was doing prior. So we were also hearing about how having access to a reliable, safer supply reduced risk of interpersonal violence and increased safety for clients, whether it was from not having to buy drugs off of people they didn't know, or not having to engage in survival sex work. Those are the two most common things that were discussed, both of which expose them to risk of victimization. As this first quote explains, I don't have to go trying to buy drugs off people that I don't know, or the risk of them selling me something that it's not what it's supposed to be, and just people trying to rob me and all that dangerous stuff. Yeah, there has been an effect for my personal safety, yes. Since people didn't have to, or told us about how they didn't have to chase after their drugs daily, their stability really improved. As this second quote shows, it was a lot better. I was able to maintain stable housing for about 1.5 years. I stopped doing crime or seeing the men and stuff like that. So it significantly helped me get stable. And we heard even more about how in allowing them to stop doing things they didn't want to do, it allowed them to do things that they wanted to do, such as obtaining employment and potentially reconnecting with family in a variety of different ways. no longer having to victimize others, as folks were telling us, or do things they didn't want to do, whether that was commit crimes or engage in survival sex work in order to obtain drugs. Many clients started to have, as they told us, a new and more positive sense of self. So people understood that their actions prior to being on the programs and doing those kinds of things were hurting others in their community, as this first participant explained. It's hurting people too. They work hard for the money, and I felt guilty for having to do those things, but they wouldn't understand why. I don't even understand why. It was just the addiction. So not having to engage in those activities that they didn't want to really allowed them to also think of themselves in a new light. As this second participant shares, I'm not prostituting as much because I don't have to make as much money as I used to. I didn't like having to do it, so it makes my self-esteem a little bit better. And we heard a lot of that about folks talking about how it allowed them to feel normal or be normal in their own words, and how their self-confidence and self-esteem improved as part of that as well. So for those clients who did experience incarceration while on Safer Supply, most experienced interruptions to their Safer Supply, as this first exchange shows. So as the interviewer asks, and so when you're in jail, what did they do about your safe supply? And the participant answers, nothing, they just cut me off. They didn't offer you any methadone or anything? No, because I was in jail, they didn't offer me nothing. And as this second participant discusses, although the withdrawal was really horrible, they were really happy and motivated to know that once they got out of prison, that there would be a prescription waiting for them. So to be thrown in jail and going through withdrawal was horrible. But whenever I got out, I had that prescription waiting for me. And providers also spoke about having to start clients at lower doses after they'd been cut off. I didn't have room for this quote here, but a physician told us about how, if they had, if folks had been in jail cells or in hospital and they'd had nothing for 3 days, they really worked to go downward with them, so they weren't giving people too much. And then, as this last quote shows here, although physicians recognized the current limitations of for Safer Supply in jails or prisons, some believed that clients were being offered alternatives like methadone, Suboxone, and as the previous two quote showed, that often wasn't the case that clients experienced. So here the physician says, that being said, there's a lot of limitations. So I have not yet had a jail physician that was willing to continue Safe Supply. I understand that, right, about the nightmare it would be on the range, but everybody so far has been converted to either methadone or buprenorphine when they're in jail. And again, as the participants were telling us that that was often not the case for them. So in terms of, just wanted to now chat through some of the conclusions from this research, and then also share some next steps, because this is sort of our preliminary analysis, and we're still working and have some plans with our analysis. So I wanted to share that, and then also some next steps with related research. So just starting with those conclusions to begin. So our research really provides some preliminary evidence that Safer Supply may result in far less involvement in criminalized income generating activities like theft and survival sex work. And some clients were able and told us about how they stopped those activities altogether. So this evidence builds and kind of comes as a bit of a pushback against some of the backlash that Safer Supply has been receiving around creating potentially more crime. Having these programs has also, as I've shared, created many benefits for clients, including reducing involvement with the criminal legal system, and in the case of incarceration and arrests, as we heard from clients, and then potentially also, as we heard them explain, around increasing safety and stability and improving their self-identity. So Safer Supply programs really have that potential to increase safety and stability for folks. However, we also have to consider the social and structural issues that are ongoing in terms of income and food and housing security that also impact all of this, and Safer Supply programs can't attend to all of those issues, but can be one of the ways of supporting folks. And as we heard, they really were. Also, although Safer Supply programs have potential for significant impact, currently there is limited intake capacity in these programs. They're small and they're really taking on high needs clients. We heard a lot about this. I won't share a lot of this here, but we do have some research coming out around this, some papers coming out around this. So that just brings us to also there being a need for a wider range of Safer Supply programs, including non-medicalized models like compassion clubs, and the need to think more deeply and advocate more broadly for drug policy changes, including decriminalization. And there's also a need to examine the continuity of care to ensure that folks who are incarcerated can get their safe supply or get alternatives, and then get set back up into the program upon release. So something that we were hearing there being a lot of challenges around from what folks were sharing with us, and maybe some issues there. So in terms of next steps, as I said, these are sort of our preliminary results, and we're thinking through how we're going to look at this. So one of our approaches, and something we've been inspired by, is this recent material turn and assemblage thinking in critical drug studies, informed by so-called new materialism and sort of the constellation of related theories there, which view matter as active, relational, and in process of becoming with the world, rather than static and inert structures. So this shift really displaces the human agent traditionally at the core of research and policy, to consider sort of emerging configurations or complex sociomaterial assemblages made up of really a diverse form of matter, including human, non-human technologies, objects, discourses, spaces, memories, desires, etc., and how these agents mutually shape our common world. And this new materialist scholars are really keen to identify sort of the mechanisms and outcomes of power relations, and the means by which human and non-human assemblages come together in ways that can create disadvantage, advantage, and inequalities, and shape human capacities in relation to the consumption of drugs and related outcomes. So we're using this and thinking through how that might also help us to problematize some of the taken for granted assumptions that we have in conceptualizing drug use and crime, and the relation between those. And just as an example of some of the themes that we're trying to look at. So I'll draw you back to some of the early examples about lesser or less involvement with the criminal legal system, and how the client had talked about being put in prison a dozen times and also going to penitentiary and then ending up with quite a record. And so considering that the non-human element there and seeing that connection relation to the materiality of the criminal legal system, and thinking through, for instance, like criminal record, and considering, what agency that record may have and how it acts upon the client, and vice versa. And then also thinking that second example there, about being that woman talking about being in jail and not being able to stay away from jail, and her recounting the story of being asked how long she'd been there, and the guard turning around and saying, since the concrete's been poured. So thinking about jail and prison as a space and a physical space, and being part of the building or a permanent fixture is another thing that we're thinking through. And then also I can just give a bit more of an example here around hearing from folks about not having to chase drugs every day or spend time doing things they didn't want to do. They talked about having more time. So this idea of creating more time is something we also want to look at a little bit more deeply, and time as an entity to consider, and having that time to do what they desire to do. So here I've just pulled two quotes that sort of connect to this. As this client shares, well, I definitely have more time, and I don't have to do certain things. I have a prescription. So again, considering what that means, and that as also an entity to look at. It's been a relief that way. I'm not doing anything illegal or anything to get money for dope. It's been good that way. And then as this nurse practitioner states, everyone actually says it's great not to have to boost or do as much sex work to keep going. And some folks have really started talking about the future. So that was part of a quote that I had shared earlier, but like looking at like how timelines and time and that concept has changed for folks as well. So this is one of the ways forward with some of the data that we're looking at, and we're thinking that new materialist approaches will really allow us to start to consider, the full complexities of safer supply programs, and provide some interesting opportunities that we hope to more fully explore in some upcoming studies with safer supply clients, and then also in this data as well. And then based on some of the lessons that we learned from this broader project that I've shared with you all today, these included that, the programs are impacting clients' lives in a variety of different ways that we weren't thinking to ask about, but were being shared with us nonetheless. Also during that project, we heard from folks discussing sort of the difficulties in recall and memory issues linked to a variety of different reasons, including benzodope, but also including the stresses that they were going through around the overdose crisis, the housing crisis, and COVID as well, and other things. They were really, facing some challenges in being able to discuss some of their experiences. So we tried to consider unique approaches and ways to support folks in sharing their stories. And then also we saw the need to consider, what the experiences on these programs might be like for women and gender diverse folks, as they were one of the priority groups or criteria for admission to these programs a lot of the time. So we wanted to understand sort of what that experience was like for that group. So based on all of those lessons, we have a new study that's just launching that I'm leading, and several members of the broader team here are also on, and Vicky's actually also a co-investigator on this project, really looking at women and gender diverse people's experiences of safer supply programs through the medium of photos, and taking an arts-based and photo voice approach to that, to learn what it means to be on these programs, and then also to get a sense of how these programs have impacted the lives of women and gender diverse folks. So this is sort of some of the next steps for me in my research around these topics. So I just wanted to end there by saying thanks to Vicky and the Capacity Unit for giving me the opportunity to present this research to all of you today, and also thank you to all of you for being present. And I guess I'll open it up to questions, and also maybe stop sharing so we can see each other. Okay, there we are.
All right. Oh, thanks, Katherine. That was great. And Michael, I'm just going to hand it over to you. Hi, how are you? As you drive, I think.
As I'm driving to see go to my clinic. Hi, Michael Gartner is my name. I'm a nurse practitioner was in Vancouver. I moved to Victoria most recently, but I worked in downtown East Side in a CHC for the last 7-8 years, and so I cannot emphasize how appreciative I am appreciative of your research for so many reasons. Thanks for letting me speak first, just because I have to head into a visit shortly as I park. But the one thing I wanted to just point out, which as a clinician I appreciate so much, is the aspect of your clinical endpoints that you were chasing, which included the criminal activity, the decrease in sex work, the decrease in needing to engage in certain activities to acquire, as well as the aspect of having more time to do things that you're interested in, or at least learn to figure that out. Because as of right now, one of the big pushbacks, and I can also appreciate as a clinician that reality, is a lot of our clinical endpoints from safer supply prescribing, not from the OUD prescribing, but the safer supply prescribing, is the fact that it has not necessarily decreased people's overall substance use. So people still continue on using illicit substances, and so overall, if you, from a mass perspective, safe supply have not necessarily, if you were to look at the clinical endpoint of ongoing substance use. And I find the pushback from some clinician colleagues, as well as the concerns, are justified, but it's also understandable because they sit within the biomedical model that still looks at that very, or that only clinical endpoint. And so I'm the reason I'm so excited about this type of research that you're conducting is that you're starting to look at other clinical endpoints, and that the hope is that hopefully with that you will provide enough confidence for clinicians and new clinicians to start using those as your clinical endpoints as I'm prescribing these medications that, it's a huge gray area. I mean, I know in BC we're providing safe supply at such a reduced amount that is not even close to enough. It's 112 milligrams of hydromorphone, where I'm theoretically by regulations I'm maxed out, which is chump change in comparison to what people actually would need. Yet I'm prescribing it, and should I not? But the whole point is it provides ease to clinicians if we learn to shift our thinking to other clinical endpoints. And it requires this type of research to look at some of those. And that is just what I wanted to say thank you for.
Yeah. Thanks for sharing that. Yeah, it was part of what we wanted I guess not what we set out looking at, but because it was sort of brought up in a lot of the interviews that we were conducting, we really wanted to give voice to that and sort of see what were some of the broader impacts of these programs, not just looking at, if it was reducing use of drugs from the illicit market. And I think you kind of tapped into one of the main issues there, is that folks are restricted in terms of dosing and in terms of the types of drugs they're able to provide to clients as well. So that impacts whether or not they're going to decrease their use from the illicit market and stop using that as well. So those are all things that I think, have to continue to think about as we go forward here. But I'm happy to hear that you're excited about our research. Thanks for that.
Thank you. Leah, please go ahead.
Hi there. I just wanted to thank so much for the invite to this. My name's Leah. I'm a MSN student at UBC right now. I've also done a little bit of work in the downtown east side as well, working at Insight. I had a question that's kind of on the note that Michael ended. Yeah, in Vancouver, safe supply hasn't really caught up to what's on the market right now on the streets. I wanted to know a little bit more about, you're talking about incarceration kind of being a hindrance or like something that pauses people's safe supply progress. And just anecdotally from my experience working in the downtown east side, I noticed a lot of clients had a lot of frustration with the titration process coming up to a therapeutic level on safe supply. I was wondering if you had any more words or like insight for prescribers and clients around this experience, any other factors that disrupted people's care with safe supply, and if there are any stories that people had about potentially dropping out of the program due to not receiving the sort of therapeutic dosage that they're looking for.
Yeah, thanks for all those important questions. So I think I'll start around the other disruptions that we heard about. So primarily the two main disruptions that we heard about from clients, and then also mirrored in what some of the service providers were telling us as well, was this disruption around incarceration, and then also, unfortunately, their safer supply being disrupted or not followed through on when they were hospitalized. So those were the two main ones that sort of came up. I think for some of these programs, and again, they were very small programs, so they had limited capacity in doing this, but I think service providers really went above and beyond to try and connect, especially when it was on the hospital side of things, and try and see if there was a way that they could help to continue that safer supply when folks were disrupted in that way, and they had varying levels of success. There were some programs that had better back and forth with some of the hospitals in town, so they were able to do that, I think, at varying capacities as well. And can you just remind me the second part of your question? We can get into that.
I was just saying that anecdotally, I found that a lot of clients are often frustrated with having to retitrate up to a therapeutic dose. Just wondering if there's anything that came up kind of along that vein. And also just like that sort of idea of like safe supply not being able to reach the potency or the effectiveness of what's available on the street.
Yeah, so we definitely heard about that from folks. They were appreciative and talked about how it was great that these kinds of programs now existed and they had access to them. But we heard things around the lines of, it's great that they give me this and I have something of a known quality and quantity, but the quantity piece is just not, the dose is just not enough. Like, this is enough to like get me out of bed or maybe get me to lunch, and then that really left them open. And I think this was speaking back to Michael's point as well, that folks then had to figure out how they were going to supplement that, and that for many of them meant going back to the illicit supply and trying to supplement that on a daily basis. And providers talked about how this was a stress for them, but a lot of the times there wasn't much they could do in terms of regulations and being maxed out. I don't recall too many folks in this study talking about dropping out, even from the provider perspective. For the most part, it was losing contact with folks for other reasons that added to that, but we didn't have a lot of conversations around that secondary point.
Thank you so much.
Thank you. Anyone else? Any questions, comments for Katherine in these last few minutes that we have? I'm just looking around the screen. No, I think it's, yeah. Yeah, Katherine, just I want to, on behalf of everybody and in our last 2 minutes, just say thank you. And that it's great to see this work, and just personally great, and thanks for inviting me into the team, and for being part of our capacity team, and helping us start to grapple and think about some of this work, particularly around criminalization and that. And as Michael and Leah and you have talked about, sort of our outcomes and indicators, and really unpacking kind of moving out of that traditional kind of approach to thinking about those bigger structural drivers, and then that intersection that people have every day on the ground when that happens. So yeah, if nobody has any more questions or comments, I'm sure just welcome. Feel free to join me in saying thank you to Katherine. It was a great talk, very informative, and just really great work, really neat. And we don't, the other piece that I just want to add is that, as providers, we don't often get, and clinicians, we don't often get asked in the way, in this integrated kind of way, with having, clients and community members and clinicians. And so it's just so neat to be able to have that kind of multiple and varied perspectives within and between the various groups that come together. And certainly we're seeing there's a huge need for, instead of either or, but how do we bring folks together and have these kinds of conversations. And yeah, I'm very excited about the Photo Voice project and the others, and look forward to more of these findings coming out. And yeah, thank you everybody for taking time today to join us. We will have this available online eventually and that kind of thing, and we'll share, and it'll go to those, particularly those who they were unable to come today. And yeah, it's great. So thank you. And I hope everybody has a great rest of your afternoon, or getting into your evening, depending on where you are, and across my screen here. And yeah, I look forward to connecting with all of you again in the future. Thanks, Katherine, so much.
Thank you. Thanks so much for having me. Thanks, everyone.
Bye, everybody. Thank you.